Good morning, everyone, and thank you, Mario, for putting this excellent symposium together. I don't know whether this was intended or not, but you had put this all in right sequence. The first clinician, Tumor, saw the patient, then it got to radiology, and after radiology, the biopsy came to us. So pathologist has the last say in this session. And then we'll leave it up to the folks, the surgeons and the transplant folks to come later. So with that, I'll talk about the role of biopsy in this setting. And the reason for this topic is that most of you are aware that worldwide, the trend in the field of hepatology has been to do less and less biopsies. And this is due to many reasons. That there have been significant advances in the field, particularly imaging techniques, that the biopsies are not required. And that's with a very good reason. However, with advances in the field, our field is changing as well. And now there are newer indications and different reasons for biopsying. And today my goal is to show you that actually the biopsy is more important in today's context than before. So the question is, why biopsy? And when you think about biopsy in the setting of liver cancer, you're always thinking of biopsying the tumor. But people don't realize that biopsying the background liver is equally important. And this is something which we had sort of learned decades ago here. And you have heard this earlier in the morning, that the status of the background liver has a very important impact on the management of these patients. And while we learn a lot from the clinical data and the imaging data, there's an important role of the biopsy, which I will show with some data later on. Then you have heard how good the imaging is. Many of these lesions are diagnostic on imaging and really don't need to biopsy. But there are lesions that are atypical and do need biopsies. And then there are cases where the radiologists are making mistakes, very rarely though. Then when you look at the biopsies, this is something which we have known for years, that grading of these tumors has an important impact on patient management and prognosis. I'm not going to talk much about that, but we have not been talking about subtyping hepatocellular carcinomas. And we have always taken hepatocellular carcinoma as one disease, and today I'm going to show you that actually it's not one disease, but many diseases put under one umbrella. And this is something that is impacting all fields of our medicine today, which is the role of genomics, and we will touch on that towards the end. So as I mentioned, the background of the hepatocellular carcinoma, the background liver, is very important, and that has significant impact on patient management. And we have been, with the help of our radiologist colleagues, analyzing the background status of liver cancers for over 10 years now. And once this data is complete, we'll have a much more better idea of how it makes a difference. But I put together a small subset of this data that is shown here. We analyzed these paired biopsies where the biopsies were performed from the tumor as well as the background liver. And this was data from 2000 to 2011, where we had such 28 paired biopsies, where in 4 of those patients, the diagnosis of the background liver changed the management of the patients. In these 4 patients, 3 patients had no evidence of cirrhosis on liver biopsies that were clinically suspected of cirrhosis. These were either stage 3 or less of fibrosis, where in 2 cases, this led to surgical excision of the tumor, which was not initially considered. And in 1 case, it led to a more aggressive TACE therapy. In 1 case, the biopsy actually showed cirrhosis, which was not clinically suspected, again changing the management in the patient. So this is not a small percentage. In this particular small series, 20% of the cases had significant impact from the diagnosis of the background liver biopsy. So apart from the tumor itself, where you will have more data about the cancer, the background liver disease may have a significant impact on the management of the patients. Now, apart from the fact that the presence of cirrhosis or absence of cirrhosis has an impact on management, the diagnosis of certain disorders in the background liver may also have impact on these patients. And while viral hepatitis, whether it's B or C, and many other conditions are very well diagnosed clinically, there are certain conditions which are sometimes first time diagnosed on biopsies. And that's where, again, the role of background liver biopsy is very important. And among these conditions, autoimmune hepatitis, NASH, alpha-1 antitrypsin deficiency are few disorders. This list is long, but these are the main disorders that are sometimes first time diagnosed on liver biopsies. And considering this aspect of understanding the background liver, I think you should seriously consider biopsying the background liver, at least in a select group of patients. Now, the role of background liver is not all important in malignant tumors, whether you consider hepatocellular carcinoma or cholangiocarcinoma. This is also very important when you're considering any other hepatic mass lesions, particularly when benign lesions like hepatic adenoma and focal nodular hypoplasia. These lesions do not occur in the background of cirrhosis, and many times that information is not available or incorrect. So I just want to make a point that when you are considering these things in your differential diagnosis, understanding the status of the background liver is equally or more important. Now, coming to the fact that imaging has become so good, and we are so thankful to our colleagues in radiology that we have the diagnosis of hepatocellular carcinoma based on imaging most of the time correct. But like anybody else, even they are not perfect. And there are reasons that the hepatocellular carcinomas may look atypical on imaging. Now, there are not many studies that have systematically looked at this aspect, why some of the hepatocellular carcinomas look atypical on imaging, but there are some studies, and based on our own experience, these are the various reasons that some of these lesions look atypical on imaging. If the lesion is not a pure hepatocellular carcinoma, but a combined hepatocellular cholangiocarcinoma, that's one reason. If the lesions have extensive hemorrhage or necrosis or cystic degeneration, they can look atypical on imaging. If they do not have a compressed liver parenchyma in the periphery, they may not have the pseudocapsule. If the lesions are very infiltrative in nature, they may not, again, have typical imaging features. Sometimes presence of fat, or if the lesions are small and extremely well differentiated, which you already saw in Jeff's presentation, they may not have classic features. Presence of portal vein thrombosis may, again, give atypical features on imaging sometimes. Certain subtypes are prone to have, again, atypical features, and we'll talk a little more about this later on. And presence of some abnormal expression of bile salt transporters has been also associated with abnormal imaging features. So, having said that, when we biopsy these tumors, one of the reasons that many times we don't consider biopsying is we considered hepatocellular carcinoma as just one disease. And there are reasons for that. For decades, hepatocellular carcinoma is considered something which is very poor in terms of prognosis. All of them were treated similarly. And knowing what actually made up this cancer didn't change your management. So these were all considered under one big umbrella that this is just hepatocellular carcinoma and there's nothing more fine-tuned to this one. However, as we have learned more and more, especially with the genomic analysis of these tumors, that this is not one disease. There are many different things hidden under this big umbrella of hepatocellular carcinoma. And just to illustrate that, you see this one example of a resected hepatocellular cancer. And this lesion, first of all, had this central scar. And this is a real case. This was clinically diagnosed as focal nodular hyperplasia and resected. However, it turned out to be hepatocellular carcinoma. But if you look at the tumor, it has many different appearances in the different areas of this lesion. And if you look histologically, some areas look like this, which looks like steatohepatitic type hepatocellular carcinoma. Some look pseudoglandular, some look like trabecular, and this is the final worse or higher grade lesion, which even has the Yale sign on it. Okay. So hepatocellular carcinoma is truly a heterogeneous disease, has many different phases, and with advances in understanding the genomic basis for all those things, we are able to understand different subtypes much better. Now, what I showed you, all of that can happen in the same tumor, or sometimes some of the tumors may have a predominant feature or predominant pattern that if significant, we start calling them as subtype. And although these subtypes have been recognized for many decades, now with the better understanding of their molecular basis, we are trying to give them distinct names, and they have distinct prognostic connotations, and many of them have distinct molecular and genetic pathways. And that allows for us to not only modify our management, but develop therapies which are now directed against specific subtypes. The various subtypes that there is a very long list. This is a smaller list just to show you some of these subtypes which are becoming important clinically and are relevant to our discussion. One of them is fibrolamellar carcinoma that has been recognized as a distinct tumor for over a decade. More recently, this is macrotrabecular hepatocellular carcinoma, clear cell hepatocellular carcinoma, Schirrus hepatocellular carcinoma, steatohepatitic hepatocellular carcinoma, lymphoepithelioma-like hepatocellular carcinoma, hepatocellular carcinoma with stem cell features, chromophobe hepatocellular carcinoma, and then combined hepatocellular and cholangiocarcinoma. So to illustrate this kind of evolving paradigm of different kinds of liver cancers, this is one which we have known for over decades. This is the fibrolamellar carcinoma. This is characterized by cells that are very large, have oncocytic cytoplasm. They have prominent nucleoli, they have pale bodies, and very characteristic fibrosis that gives the name to this tumor. So this is something which we have known for decades. These tumors occur in younger patients, mostly occurring in non-cirrhotic livers, and often not associated with viral hepatitis. The alpha-fetoprotein levels are usually not elevated, and this is supposed to have a good prognosis, which is largely attributed to the fact that these arise in non-cirrhotic livers. However, more recently, we have identified that these tumors are characteristically associated with a gene fusion with DNA JB1 PRKCA gene, and this fusion is very characteristic of this tumor, that it is now used as the diagnostic marker or even a gold standard diagnosis for these kind of tumors. What it also does, it allows us to have a potential target for therapy, and that makes it very exciting. Another tumor type that is recently kind of recognized and is getting significant attention is the so-called macrotrabecular massive hepatocellular carcinoma. This is a tumor that is characterized by very thick hepatocyte cords, which in different studies have been either identified as more than 6-cell plate thick, or some studies more than 10-cell plate thicks, and these are lined by endothelial cells. It's a very characteristic morphology. These tumors tend to be large. About more than 50% patients don't have background cirrhosis. When they do have hepatitis, they are more commonly associated with hepatitis B. They have often very high levels of alpha-fetoprotein, and they often have high grade and high stage and AJCC method with very high incidence of vascular invasion. All of this mean that these have poor prognosis with high recurrence rate and worse recurrence-free survival. And more recently, people have recognized that these are associated with mutations in the P53 gene and amplification in FGF19 gene, and also high expression of vasculogenic factors like angiopoietin-2 and VEGF-A. And again, this is very exciting because this now gives a potential target for treating such patients when they have this phenotype. Another phenotype which is very interesting is so-called Schirrus hepatocellular carcinoma. These are certainly not common, constitute less than 5% of all hepatocellular carcinomas. These are the tumors that can be very atypical on imaging, and these have many unusual histologic features as well. They have many features that overlap with cholangiocarcinomas, with some of the immunohistochemical markers of cholangiocarcinoma like CK7 and CK19 expression, and less expression of some of the hepatocellular markers. Even at the genomic level, they have shown that there is some overlap with cholangiocarcinoma in these tumors, and prognosis of these tumors is generally very poor. And now people have shown that these tumors have mutations in TSC1 or TSC2 genes, and these tend to show this epithelial to mesenchymal transition gene expression. Another interesting phenotype, steatohepatitic hepatocellular carcinoma. And these tumors have all the features that you associate with what you see in patients with steatohepatitis. The tumors have fat, they have cell ballooning, they have mammillary hyaline, and they have pattern of fibrosis that you see in patients with NASH. One would think that these tumors occur only in the setting of patients who have NASH, which is largely true but not entirely true, because patients with this kind of hepatocellular carcinoma sometimes do not have any background liver disease. They have no evidence of metabolic syndrome or NASH in the background liver. What's happening there is not entirely clear. This subset of tumors has still not been studied very well. A lot of things remain unclear about this subtype, but generally people feel this is a well-differentiated tumor and generally have a good prognosis. At the molecular level, a subset of these tumors have loss of 9q, and activation of IL-6 JAK-STAT signaling pathway has been associated with this set of tumors. This is a very interesting variant, the so-called lymphocyte-rich hepatocellular carcinoma, or the other name for this tumor was lymphoepithelioma-like hepatocellular carcinoma. And these tumors are very interesting because they have a significant infiltration in the background liver by immune cells, lymphocytes. And while these have been reported to be rare in the literature using the older criteria, if one looks at the just presence of increased number of immune cells in these tumors, these are not that uncommon. And why this is exciting is because now with all the advances in immunotherapy of tumors, with immune checkpoint inhibitors, this is a candidate subtype which will be very good to see how these do with the newer modes of therapy. Some of these tumors are associated with the EBV expression in the tumor cells. Tumors of this type in other sites are often microsatellite unstable. However, in the liver, so far, these tumors have been shown to be microsatellite stable. These tumors generally tend to have a good prognosis. However, so far, studies on this kind of tumors are limited and no unique molecular signature has been identified. So with that kind of a background, we are moving from a morphologic diagnosis now to a more molecular diagnosis, where like previously we used to say the patient has just hepatocellular carcinoma, now we may be moving towards a era where you will be saying hepatocellular carcinoma, a certain subtype, and activation of certain pathway. And that would make it a complete diagnosis. So what it says is all about genes. So this is something that has happened to all the different tumors and various other fields in medicine, that the genomic analysis has changed how we think about things. In hepatocellular carcinoma, it has also occurred. There have been significant publications in the recent years that have led to much better understanding of the molecular makeup of the hepatocellular carcinomas. And largely 9 different kind of pathways have been implicated. I don't expect you to read all this kind of things. These are some things that I think Stacy is going to address in the next talk about what pathways are important in hepatocellular carcinoma and how they are being targeted. But what it says is that hepatocellular carcinoma, based on morphology as we knew, was many different kind of disorders. Many different kind of patterns existed. On molecular basis, now we are understanding that this is entirely true. There are many different pathways, and some of them have very good morphologic correlations. So I'll illustrate the use of a biopsy in this setting with a case. This is an example of a real patient which we saw at Yale, a 60-year-old male who had multifocal hepatocellular carcinoma in a background of cirrhosis. The patient had portal vein thrombosis and ascites and had developed multiple lung nodules suspected to be metastasis. Now, how many people in this audience would like to biopsy this patient? Please raise your hand. If I add that this patient also had elevated alpha-fetoprotein, probably nobody. However, biopsy was performed in this patient, which confirmed what you already knew, that patient had moderately differentiated hepatocellular carcinoma. But now that there are certain therapies available that can be helpful in certain phenotypes, we had kind of moved to doing certain other tests. So this was subjected to MSI status or DNA mismatch repair enzyme assessment. Unfortunately, this was DNA mismatch repair enzyme preserved or what we call microsatellite stable. So this did not lead to a specific therapy. Next one online was the one something every other oncologist is so keen to know about, which is the PD-L1. And this also has a specific therapeutic implication. This was tested, and this was also negative. So then what? Well, then this was sent for genomic analysis with an assay which we call Oncomine assay. This assay has over 140 genes that are evaluated. You don't have to read all these genes, but these genes have been selected because these are very important in cancer, and they are thought to be driver mutations or mutations against which you could have targeted therapies. So these are highly selected gene panels, and from this analysis, this particular tumor was found to have mutations in T53, TSC2, retinoblastoma protein 1, and CDKN2A genes. And the most important of this was mutation in the TSC, or tuberous sclerosis 2 gene, because there are this has an impact, or this has activity in the mTOR pathway, and there are inhibitors that are available in clinical trials that this patient may benefit from. So this patient, where there were otherwise no lead as to where this patient should go or what kind of therapies may be available, based on genomic analysis, at least there was some hope. So this is my sort of concluding slide on genomics, that while we have a lot of genomic data on hepatocellular carcinoma, in liver cancers, cholangiocarcinoma is a slightly better target for targeted therapies and clinical trials than hepatocellular carcinoma, but there are several other things that are still available. And again, you are going to hear more about this from Stacy in the next session. And there are certain other things that we are experimenting with at this time, and which we think are going to advance our knowledge in this whole area of analyzing tumors and help us understand liver cancers better. Right now, I don't have real data to show you on those things, but we are evaluating these things. One of them is three-dimensional microscopy, which allows us to look at this tissue in 3 dimension, not in the 2-dimension traditional H&E slice that we have been doing for centuries. And that hopefully will allow us to do not only AI on those things, but better digital morphometry, which can give us more insight to these tumors as well as background liver disease. Also, now we can apply mass spectrometry on tissues at the cellular level, which will help us to understand not only like we are doing with genomics, but also with the cellular composition at a very high resolution to understand what's going on at this very in-depth cellular level functions that hopefully will help us better manage these patients in the future. With that, I'd like to thank you all for your attention, and we'll next move to the question and answers. Thank you.